Hello and welcome to this edition of the GIE Author Interview Series. I'm Sunil Amin, an Associate Professor and System-Wide Director of Endoscopy at the University of Miami, and I'm joined today by my co-authors, Drs Rahil Shah and Shyam Vedantam, who are currently third-year GI Fellows in our division. Today we'll be discussing our recent publication in gastrointestinal endoscopy, evaluating outcomes of gastric peroral endoscopic myotomy, or GPOM, for refractory gastroparesis. In this study, we conducted a meta-analysis comparing outcomes based on the greater versus lesser curvature approach to GPOM. Before we dive into the findings, let's set the stage by discussing gastroparesis and the rationale behind GPOM as a treatment option.
So, gastroparesis is a debilitating motility disorder characterized by delayed gastric emptying in the absence of a mechanical obstruction. Common etiologies include diabetes, post-surgical states, medications, autoimmune conditions, and other idiopathic causes. First-line treatment focuses on dietary modification and lifestyle changes, and in addition to prokinetic agents. But these are often inadequate. For patients who fail medical therapy, endoscopic and surgical interventions are considered. One promising approach is GPOM, which involves an endoscopic pyloromyotomy by creating a submucosal tunnel to cut the pyloric sphincter, thereby improving gastric emptying.
What's particularly interesting about GPOM is that there are two primary approaches, the traditional greater curve approach and the more recently proposed lesser curvature approach. The greater curvature approach has historically been favored due to the natural alignment of the scope. However, the lesser curve approach offers some theoretical advantages, like a shorter submucosal tunnel, easier orientation, and possibly reducing the bleeding risk due to the decreased vascularity, which might overall improve the overall procedure time and risk of complications. Despite these hypotheses, no consensus exists of which approach is superior. That's what motivated our study.
Exactly. With that context, we performed a systematic review and meta-analysis to investigate whether outcomes actually differ based on the approach taken. Rahil, can you walk us through our methodology?
Sure. So we queried major databases from 2000 all the way through November of 2023. After reviewing studies, we included a total of 16, which met our inclusion-exclusion criteria, and it totaled 621 patients. 460 of those underwent GPOM via the greater curvature approach, and 161 via the lesser curvature. Our primary outcome was technical success. Secondary outcomes included clinical success at 3 to 6 months, clinical success at 12 months, GCSI scores, gastric emptying study, procedure time, myotomy length, length of stay, and adverse events. We used random effects models and performed subgroup analysis between greater curvature and lesser curvature groups where possible.
Our meta-analysis showed a pooled technical success rate of 98.5% overall, with no significant differences between the greater curve and lesser curve groups. The pooled clinical success rate at 3 to 6 months was 77.3% for the greater curve and 65.2% for the lesser curve. Again, without a statistically significant difference between the approaches. Where things got interesting was in some of the secondary outcomes. So while there was no difference in GCSI at baseline, when looking at 3 to 6 months, the GCSI scores favored the greater curve approach compared to the lesser curve approach, 1.2 versus 2.4 respectively. This was statistically significant. The lesser curve approach also had fewer mild adverse events, 1.2% versus 9.6%, and shorter length of stay, 1.5 days compared to 2.1 days, compared to the greater curve approach.
Right. And so while both approaches had high success rates, there seems to be a trade-off. Better symptom scores short term in the greater curvature approach, but less morbidity and resource utilization in the lesser curvature. It's important to note, though, that the heterogeneity in definitions, especially for clinical success and adverse events, makes direct comparisons tricky. Also, most included studies were from high volume centers, which may limit generalizability.
This analysis raises important considerations for procedural planning. So what should our key takeaways be?
First, GPOM is a technically feasible and clinically effective therapy for refractory gastroparesis. Second, Both greater curve and lesser curve approaches are viable, but the choice may be guided by factors like provider experience and institutional preference.
Future prospective randomized trials should aim to standardize definitions, examine long-term outcomes, and explore cost-effectiveness between approaches. Incorporating objective measures, such as using EndoFlip, may also help in better patient selection.
Thanks, Rahil. I think to summarize, at the end of the day, this meta-analysis has shown us that both approaches are similar with regards to clinical, technical success, and certainly any serious adverse events. At the end of the day, it just depends how you were trained and which approach you're most comfortable with. I've noticed that initially many surgical oncologists or surgical endoscopists, I'm sorry, were using the lesser curvature approach, whereas gastroenterologists tended to work along the greater curve. Though I think the tide may be shifting. I know that many gastroenterologists now have actually shifted to the lesser curvature approach. Regardless, I think we'll leave it at that. Thank you for joining us for this discussion. We hope our work contributes to the ongoing refinement of GPOM techniques and improved outcomes for patients suffering from gastroparesis. Thanks.
Thank you.